Hotbed Talk.
So we're going to move on to our final speaker of the session. It's a great pleasure to welcome David Probert. He's CEO of University College London Hospitals, very large and complex organisation just down the road, and has previously been CEO at Moorfields Eye Hospital in London. He's an honorary professor at UCL and actively involved in teaching and training around clinical leadership and management. Great pleasure to welcome David this morning.
Thank you. Morning. Good morning, everybody. It's wonderful to be here. I hope what I can do is present an organisational perspective and hopefully help some of you, particularly those of you that work in the NHS, understand some of the challenges that we're facing, some of the obstacles that you face on a regular basis and how we can overcome them in the spirit of innovation and many of the things that you've been talking about at this conference. The reason I put up a bit about my history, this is where I come from. I've been in the NHS now for 26 years. In all of these hospitals, people have talked to me about things like enhanced recovery, opportunities for growth and innovation. They've also claimed, which will be important to something I'm claiming later, that they are the best at certain things. And that's really relevant when it comes to working out how you overcome some of the challenges that people like me often put in place. Probably less relevant for things like enhanced recovery is my experience at Moorfields Eye Hospital. But it was interesting from another perspective. Not only do we run 26 sites here in the UK, but we run a large number over in the Middle East as well. Just seeing the way that the world was operated there and some of the challenges that we've been hearing about earlier and here in the NHS was quite similar. And now I'm very proud to be at UCLH, where I've been for 3 years this month, in very close partnership with our colleagues at UCL, and it really is a true partnership. Everything we do together. And this particular field, and much of the subjects that you've been picking up in this conference, it's fantastic that we're in a joint institution that is really focused on how we get better and how we invest. But this is the question. Why is it so bloody hard to do anything new, even if the benefits are obvious? And for some of you in the audience, it may feel like you are constantly pushing very large weights up very jagged and very difficult hills. Of course, where all of our staff feel like they're just pushing downhill and it's so easy because of the leadership of the hospital and the organisation. But this is the fundamental question that when I was young in my career, as a young manager, people would say to me to my face. Now I'm slightly more older and slightly more senior, I think they say when they leave my office, and I've said no to stuff. But it's a really, really important question, and I get your frustration. And what I want to do over the next 5 minutes is give you a reason as to why it's so hard, which you'll know, but just a bit more insight from my perspective. And then secondly, my guide to how you do get these things to work, which I hope is helpful. So why is it so hard? Well, this is obvious, particularly on election day. We got lots of letters as NHS CEOs about the importance of purdah and not having any opinions, which I never have at work. So please just ignore the colour of the tie. You'll see here, this is the beginning of the NHS, 1948, and you'll see a steady rise in growth. You'll see, not a political statement, the beginning of the Blair and Brown years and the massive acceleration in growth. And you'll see the period of austerity and the most significant decline that we see. So we are now in a period of time where we have the largest ever sustained reduction in UK funding for the NHS. To put it in statistical format, when you looked at that period of austerity, the real serious period of austerity, if you're looking at the early years of investment in the NHS, you were looking at growth of somewhere between sort of 6 to 8%. During the period of austerity, so when things got difficult, that dropped to about 3%. Going into next year, we're looking at growth of about minus 1%. To understand how significant the challenge is and why people often can't even begin to look at new business cases and new forms of investment, this is what's blinding the eyes of many leaders in the health service. I'm very proud at UCLH that we are opening some amazing facilities in the course of the next 2 years and investing in lots of things. But I'm equally conscious that that's a very privileged position and that some hospitals around me are celebrating quite rightly when they're turning on a new X-ray machine. And that is the challenge we find ourselves at the moment. Reason one why it's a challenge is that colleagues here from across other parts of the world can see where this spending in healthcare is going against their GDP, and it's not a pretty picture. We are challenged on the money. We're also challenged because often people like me, but I hope not me, simply stare at this graph. And this shows the total waiting list. It's actually got slightly worse since then. You're talking about something like 8 million people now waiting, about 85% of them for some sort of diagnostic treatment, and about 90% of them will never hit an NHS bed. It's still a significant waiting list. So when you're coming with new and innovative ideas and ways of changing perioperative care, surgical medicine, you're coming with this great enthusiasm because it works. Some people are thinking, we've got no money. Some people are thinking, how is that going to help me see these 8 million people? Because this is how I'm keeping my job at the moment. And then this is taken actually from UCLH, but you can probably tell by the amount of green, although we do perform very well at the moment. This was some years ago. But if you look, for example, at the A&E target, I'm not sure many hospitals have hit 95% 4-hour wait for a very long period of time. But the third reason why innovation and growth is difficult, hopefully in support from a clinician's perspective, is that this is just a subset. I have 486 metrics on a monthly basis that our performance is judged on as a hospital. Fortunately, very few of our staff know any of that because we try and shield it from them. But there are core metrics, quite rightly, waiting times, infection, cancer performance, privacy and dignity. So you've got money, waiting lists, and a barrage of metrics that hit you, and none of the fantastic things we've just heard about actually fit into this, although they should. And at UCLH, particularly in areas like research and innovation, we try and make sure they do. And then we have the barrage of quite, at times, understandable challenge around the NHS and the things that are going wrong. This is actually taken from 10 to 15 years ago when my old colleague and mentor from Boston, Don Berwick, did a lot of work on safety here in the NHS. But if you open up the headlines of newspapers last week and looked at Panorama and various other things, you can see this is back. Sometimes it's completely justified. Other times it isn't. But the reality is, as leaders, when you're looking at business cases and signing off investment, you're looking at this stuff as well. How's it actually going to impact? There's the challenges we face. So when you're coming into the office and you want to invest and get that case across, bear all of those things in mind. And I'm going to give you 2 case studies and then my to-do list. Both of these are relevant in my career. The first is robotic surgery. Many of you, if I was just talking to a colleague from Melbourne who is going to be involved in this moving forward. When I was a very young manager in my 20s, I was visited by a group of urologists who wanted to start a program of robotic surgery. I was wowed as somebody who was about 26 by the idea of how fantastic this would be. 3 small 1-inch portholes, impotency, incontinence rates, pain relief. I'm not a clinician or a scientist, but I found it fascinating and thought this is something we have to do. So the argument for pushing forward something like robotic surgery always comes from the first argument, which is it is better for patients. And that sounds a bit crass and obvious, particularly when I'm in a room full of clinicians and people that give care. But I can genuinely tell you there isn't a CEO in the land that doesn't care about that as their first and abiding principle. Or if they don't, they need to be doing something else. So the first argument that was given to me about 20 years ago was a bit skeptical. There wasn't a lot of publication behind it, but the genuine argument was that it was better for patients. The second argument, which did appeal to me, over and above it being better for patients, was around recovery and length of stay. So even 20 years ago, we had enormous pressures on beds, not dissimilar to how we're facing today. Anything that could shave off time on people's average length of stay was something we had to invest in, surely. And then the third bullet is really important. It's called first mover status. So although there was a very, very famous person in London also doing urological robotic surgery, we wanted to be the first mover to do it in, I think it was live-related transplant at the time, kidney transplant. So why wouldn't we want to be the first mover? We're a big teaching hospital. We had a reputation. Why wouldn't we want to do it? Corporate ego is really important. It shouldn't be. But boards love the idea of doing something no one else is doing and doing it well. And then there's commercial opportunity, which actually did develop as a result of this. And then finally, the opportunity to do research. So when the robotic program was put to us, it was put within a context of all of those different opportunities. And then finally, we had something called Sequins, which was just starting to form. So this was where they were trying to match clinical outcomes against quality initiatives. So they would pay you to do better at something. Sequins still exists, but not perhaps as strong as they were. Our commissioner said, well, there's no way we're paying for this. Have you seen the cost of the consumables? It was quite eye-watering when I did see the cost. So what we said to them was, let's look at our pain control spend, let's look at our length of stay, commission us against improvements in both of those areas, pay us on a case-by-case basis to make sure we get better at those. They did. The program was allowed to go. The program has blossomed. But it is a really challenging cost argument, robotic surgery. So to go back to what I said earlier, here's something that people think is really good. Why can't we just do it? Is all the arguments and the challenge. And here for me was how it was sold and how I then had to go and sell it to a board. Since I joined UCLH, has probably not knocked on my door a lot and got me to come and see this in action and some of the great work that he and his team and many of you in this room have been involved in. So why wouldn't you invest in this work? Clearly, it's better for patients. It's about safety. If you have a CEO in a hospital that hasn't got safety as their biggest priority, they're in the wrong job. It's about reputation. We want to lead the way. We want to say to our patients, this is the safest place to come. We will recover you as quickly and positively as possible. There's also, again, clear arguments around length of stay. We don't know at the moment how short London is of genuine beds, but I would imagine at first guess it's at least a hospital or two short. There's big arguments around cost. And then as John and the team have demonstrated and Ramani and many others, it leads to research. With our focus with the NIHR, that's really important. So for me, just a bit of a guide on winning the argument for investment, because some of you may be wanting to knock on your CEO's door next week and push forward. Find arguments that clearly align with the person you're talking to. Because I'm an NHS CEO and I'm not a clinician, I don't have safety and patient well-being and the care of our patients at the forefront of every decision that I take. Present a case that is really based on the audience. All those slides I showed you at the beginning, waiting lists, money, all the stuff that's keeping me awake at night. How do we also play into that? Play to the ego of the person you're talking to. Wouldn't you like to be the first CEO in charge of a hospital that's doing this? Corporate ego as well as the ego of the individual. I've used that on a number of occasions in other institutions, and it does work as a tool. That first mover status is really, really key. And around us now, we've got this new system forming around incentives. So we have an integrated care system here in the UK. That system was designed to look at the patient all the way from developing an early symptom through their treatment planning to going home and being well again. An ICS is designed to provide care all the way across that. Has it managed to do it as a system? It's been challenged because we've had challenges with money and performance. But if that system stays, it has the ability to support much of the innovation. You can start to talk about things like enhanced recovery, not on the benefit to the hospital, not to the benefit to social care, but to the benefit of the entire system. So you're in a much stronger place. Things like Sequins, I think, will come back. So how we incentivize people. And what I think probably will also is payment by results. So genuinely paying for the performance that you're delivering in your care. So I hope that's a helpful how-to guide and a bit of an exposure from my perspective, and hopefully an honest view on some of the challenges that we face and why it's not always as easy, even though things seem so obvious to do them. Thank you very much indeed.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.